So we'll try to make it fast إن شاء الله ما راح أطول كثير. We'll talk about tuberculosis today. We'll talk about what is it, what caused the tuberculosis, the epidemiology and the natural history of this disease. And then we divide the tuberculosis to two things, either latent TB or active TB. Briefly, we'll talk about drug resistant and the TB in special population. So there are multiple species of Mycobacterium tuberculosis. So it's called like this disease or tuberculosis caused by the Mycobacterium tuberculosis complex. As you see, like 5 or 6 of them, but the most common will be the Mycobacterium tuberculosis, then the others kind of low frequency, like Africanum, Bovis, Canati, Benibidae, or Microti. But the Mycobacterium tuberculosis, or or as a name as a whole, they called Mycobacterium tuberculosis complex. That's what caused this this disease. It's a bacteria. It's not like the typical bacteria, but it's mycobacteria. I didn't go in details about. I mean, again, this is more like clinical oriented. I didn't go in details to talk about like yesterday about the virus, or in details about the mycobacterium, what's different about it, or what's the structure of these bacteria. So it's an important disease. Almost 1/3 of the population is infected, of the world population is infected. We have 10 million new cases of TB every year. Of course, the sub-Saharan African, again, is where the most cases are. TB is considered one of the top 10 causes of mortality worldwide. And this is like all the top 10 causes of all disease. When you look up for a single infectious agent, it's the leading cause of death. It caused like 1.7 million deaths, and that was in 2017. And another problem with TB that started years ago, but it will be a concern, is the drug-resistant TB. Here's the epidemiology. This is from 2020. Again, the most cases, as you see, in Africa or sub-Saharan region, and also so you have this area, and you have like the southeast, the Southeast Asia, China. So if you have sometimes, even if you look at Saudi Arabia, so the incidence rate is low. So if you see, like, let's say the United States, Canada, Europe, we're talking about from 0 to 9.9 per 100,000. It's the same incidence rate in Saudi Arabia, but the issue is we have a lot of workers coming from different countries around the world, especially the low socioeconomic country. You're talking about Africa or Southeast Asia. So this is an important when you take a history from a patient presenting with whatever his presentation, that going with infection or respiratory symptoms, and either the patient coming from these regions, or the patient is, let's say, Saudi, he never traveled, but he just had like a recent exposure with, or he just had a new worker from one of these countries who was coughing, and then yes, this is a significant risk. This is the report, the annual report from the Ministry of Health. In 2019, we have 3,000 cases. This include both new and relapsed cases. And the incidence rate is 8.7 per 100,000. And as you see here, the rate was like 5 decades ago was like 243 in 100,000. But there was like a really significant decline, especially in the first, from 1970. This based on the Saudi report, the National TB Program. Significant reduction or decline in the incidence from 1970 to 1990, 2000, and then this decline started to decrease. But since 2012, kind of the incidence rate stabilized. So for the last, let's say, for the last 8 years or 10 years, we're still having around the same number of new cases. And of course, the incidence is more among the non-Saudis resident compared to the Saudis. So as you see here, 10.9 for the non-Saudis compared to 7.4. Let me just go back here. No, 243. So it will be around this area here, like 50 years ago. Okay. So the natural history of TB, you get exposed to TB, you inhale this bacteria. Either your system will control it and kill this bacteria, so you don't have anything, or you will have kind of primary infection. So when you have this primary complex or primary infection, now we will come to the test. You will be positive for the screening test, but then you go one of three ways. Either you will have a primary TB infection, a localized disease, or you can go like a disseminated, go to other organs, or just stabilize. You don't have like maybe asymptomatic and just the bacteria is there, what's called latency, and then at some point in your life you might have a reactivation. The same thing goes with dissemination, either disseminated and cause an acute primary infection, like miliary TB or others, or just disseminate to different organs but stabilize. You don't have any symptoms, and then later on in your life you will have reactivation. This is the same as like just explaining how the cycle goes. A sick patient coughing, another patient inhale these bacteria, goes to the lungs, some innate immune phases, and the macrophages will form these complex. Then if really there is like a clear eradication, then you will just have like calcified. When you get an X-ray, you will have like small calcified lesion in the lung. It may be just previous exposure, and your immune system take care of it, or it just be there and latent, or at some point, which is around 10%, you will have a reactivation and you get sick, and then you cough, and then the bacteria go to another one. So this is the way it goes. Exposure. Some people will get infection, others will not. Like any other infections, like viral infection. People like sick around you. Some of us will get the infection, others not. Many reasons for that, but this is not the time to talk about them. But some of us will get the infection. Those who get the infection, those who inhale the bacteria, around 10% of them, they will go to get like an active TB or primary TB. But the majority of them, 90%, will go through latent phase or latent TB. Then those with latent TB, 5 to 10% of them, they have a risk of progression or reactivation in their lifetime. So if we said 100% infected, 10 of them will have an active TB. Then 90 of them will be a latent TB. Then you have this risk. I mean, it's difficult how to talk about it, but let's say just in general, you will have 10 of them at some point will have reactivation of their disease and get an active TB. So when you calculate, it will be like for each person, you have this risk in your lifetime, 5 to 10% that you will have a reactivation of this infection. This risk, if you is so 5 to 10% in your lifetime. If you are an HIV patient, this percentage is every year. So it's really high risk. Like people with HIV, If they have a latent TB, they have high probability to have a reactivation and getting an active TB. And then again, when we talk about the reactivation or active TB, if the 50% will happen in the first 2 years, then the other 50% later in life. What are the risk factors to get the infection? So if you're exposed to an active TB, if you are living in an endemic area, then this is a risk factor. Then also other places where crowded places, a lot of people who can be infected, like if you're homeless, if you're incarcerated, if you are in work-related work that it give you exposure to patient like us, healthcare, IV drug user, also found to be risk factors. I think it's not just because of the IV drug user, but because of the circumstances around the people who are IV drug users. Then those the risk factor for infection. Now, what are the risk factor to progress to become an active TB? If this is a recent infection, as I showed you in the figure, was like 50% of the active TB occurs recently, like in the first a year or two. So recent infection, this is a risk that it will progress to active disease. If you have fibrotic lesion in the chest X-ray, HIV infection, or any other immunocompromised status, it's a risk factor. TNF alpha inhibitors, so that's why patient who you want to start them on TNF and alpha inhibitors, you must check for quantiferon or screen for TB prior to start the treatment. Then other causes, again, diabetes, end-stage renal disease, silicosis, and intestinal bypass. I'm not sure why the intestinal bypass exactly. I have to look it up like in more details, but probably affecting some of his immune status, and that's why he's more prone to progress to an active TB. So as I said, we have two: latent TB and active TB. For the latent, there are two ways. We just do the screening. Two things for screening. Either you do the skin test, the tuberculin skin test, or you do the interferon gamma release assay, or IGRA. They call it quantiferon or gold test, but these are the two tests we have. So for the skin test, you just give the injection for the protein, and then 48 hours or 72 hours, you check the induration. It's not the erythema, it's the induration. So as you see here in this figure, this is the correct way, the swelling. It's not the redness. If you read it with the redness, this will be like false positive. I don't know why this looks like this, but anyway, it's funny because every time I give this lecture, it happens and I forget, and then I just remind me when I give the lecture, so I need to fix it somehow. Anyway, so when you do this is for the skin test. When you it's based on the induration. This column here, you see the mark, the pointer, right?
Yes, teacher.
Good. So this one is more than 5. This column here is more than 10. This one is more than 15. So let's start from the more than 15. You want if a patient come to you healthy, no risk factor, no exposure, nothing, then you're looking for 15. If it's more than 15, you consider this positive, 15 millimeter. In this category here, the one which like, if it's above 5, you consider them positive. Again, why you go with the limit to really be so, you want it really, your threshold will be low, which is 5 millimeter. If it's above that, I will consider it positive. If you just think about it logically, I will include any patient I'm worried about them. HIV patient will be there. Patient who are immunocompromised will be low. I'm worried about them. I will not wait for more than 10 or more than 15. I will say if it's more than 5, I will consider it positive. Immunocompromised, either they are taking high steroid dose, organ transplant, HIV, taking TNF alpha inhibitors, or they have a close contact with active TB case, just recent with active TB, like patient recently diagnosed with active TB and he's coughing on them. then I will take the threshold to like 5. Or the patient have a chest X-ray that's really consistent with TB finding, and you say, I'm not ignoring this chest X-ray and say I want like 15 millimeter. I will go with the 5. Then the middle category here will those who's not in these two categories: IV drug user, diabetes, end-stage renal disease, healthcare worker, people in endemic area, and so on. So for the skin test, you can have false positive. As I said, either they don't give him they don't administrate the protein in a good way, or the interpretation is wrong. They just read the erythema. Sometimes if you have a previous BCG vaccination or cancer therapy, BCG vaccination or BCG cancer therapy, it might give you a false positive. Infection of non-tuberculous mycobacteria or hyperreactive skin can give you some false positive. The false negative, again, goes with the same thing. If it's not read correctly or administered correctly. The other things they found false negative: if you have recent live virus vaccination or recent or very old TB infection, overwhelming TB disease can give you a false negative skin test. But again, this test is not for active. We're talking about latent TB here. The other test for latent TB will be the interferon. The way the interferon work, simply you take the blood from the patient. So you assume that if he was exposed to TB, then he has an antigen in his blood, and his T cells know this antigen. So you give him a TB antigen, and you wait for these T cells to respond. If they know that TB antigen, they will respond. Their response will be by producing interferon gamma. Then that means the interferon gamma will go up. You do the ELISA, and you detect them. That's mean positive. So then the IGRA test will be positive. The interferon, that's why it's interferon gamma release assay. It's usually the preferred method, especially for those who received the BCG vaccination, or if those who are worried they are infected with non-mycobacterial disease. So it's kind of more specific for TB. Also, again, it's preferred because you don't have to ask the patient to come after 2 days to read it. You just send the test, and the result will come whenever the patient comes for follow-up. False positive as a technical error because again, it's the lab technician who will read it, the lab technician who will add these things, add the antigen, add the antibodies to do the test, and also incorrect interpretation can lead to false positive. The false negative: elderly, immunodeficiency, or if you have a disseminated DB or extrapulmonary, they just so immunodeficiency. If he's immunodeficient or immunocompromised, sometimes the T cells kind of, if I don't know if this is accurate, but I mean, I'm not sure immunologically wise to say like their T cells are weak, so they don't respond. Even if they know the TB and the patient was exposed, they don't respond, and they didn't give you the good production of interferon gamma. So you don't detect them, and you think it's negative, but it's not negative. So, in just bottom line, in those populations like immunocompromised or elderly, and you're really thinking about latent TB or a good exposure, and it's negative, you can just reconsider it or think about it again, or find a way to go with what you think most likely happened with these patients. And usually, the people with subspecialized in this area will help you with that. I don't know why this below here, number 4, but this was one of your colleagues last semester. He wanted to do an algorithm, so I just corrected for him. It's simply, if a patient with history of TB exposure or individual at high risk of reactivation, like HIV, starting anti-TNF inhibitor, etc., you do the screening test. What do we have? We have, as I said, the interferon gamma release assay or the skin test. This is the preferred one. Okay, this is easier here. You say, okay, the scan is negative. If it's not the limit, then you're done. The only thing I go to tier 3, which is here, you repeat both of them. If they're negative, unless the patient is at high risk or he has a recent exposure and you still worry about his exposure, then you can repeat these tests like in 8 weeks or so. If it's positive in both sides, if it's positive, you need to exclude an active TB. If it's active TB, then you treat him as an active TB. If it's negative, then you treat him as a latent TB. Again, here it's the preferred interferon. If it's negative, you are done unless it's high risk or you're worried about the patient and recent exposure, then you repeat that. If it's indeterminate, then you repeat. If the same result is confusing and indeterminate, maybe you go on and do skin test to help you with that. If it's positive, the same story. Exclude active TB. And if it's positive, he has an active TB, treat him for active TB. If it's negative, treat him for latent TB. So yeah, once it's positive, you need to treat. But before you start treatment, you need to get a full history, a full physical exam, and a baseline chest X-ray. Why is that? To exclude an active TB. Why we need treatment for latent TB? Because effective treatment will reduce this risk of progression by 60 to 90%. So if you remember those who they have 10% lifetime risk of progression, if you give them the treatment, you reduce the risk by almost 90%. What are the regimens? Too many. Different studies now, they're trying to go low in the duration, but one of them, isoniazid and rifampicin, you give them once a week for 3 months. You can go with rifampicin for daily for 4 months. Before it was like isoniazid daily for 6 months, or daily for 9 months, or twice a week for 6 months. Again, different regimen. You can pick whatever you like, or the most likely or most common things that people use. But mainly, I would say these three you use it. For sure, if you are using isoniazid, you need to add pyridoxine for the peripheral neuropathy, and check the labs for prior and after to make sure that to make sure there is no side effect of this medication. Okay, so yeah, so we talked about this part now, the latent TB. As you said, 5 to 10, they will progress to active, most of them in the first 2 years, that 50% later in life. If you're on HIV, this risk is annual. So for active TB, it can involve any organ, but the most common, of course, will be the lungs. What's the histopathological characteristics is granuloma, caseating granulomatous inflammation. Usually when you talk about TB, you're talking about, is it primary or reactivation, as we talked about. Then another classification, is it pulmonary or extrapulmonary? Usually it's subacute or chronic symptoms. Patient usually sick, feeling ill, fever, chills, night sweat, weight loss. You don't have to have all of these things, but kind of if they're active, usually you have most of them. For pulmonary TB, you can have primary TB, although symptoms. Some of them will be symptoms free. They don't have any symptom, or they have mild symptoms, just fever, non-productive cough, and resolve spontaneously. But then the reactivation, they have it has upper lobe predilection. That's what the most common, or the things that we usually think about. There's upper lobe infiltrate or something, or cavity. Then you think about TB, but not necessarily there. Cough, hemoptysis, productive cough, and with hemoptysis sometimes. In the cavitation, more common in reactivation than primary. And then other things that you can see when you do imaging, you can see hilar lymphadenopathy, nodules. Pleural TB, some people consider it as pulmonary. Some people, if it's just pleural TB, some people consider it as extrapulmonary. But anyway, the patient can present with pleural effusion, and pleural effusion can be seen up to 25% of primary TB. in these cases, you will do pleural fluid aspiration and do the analysis, and what you will see there will be exudative effusion. You will have lymphocyte predominance. If you check the adenosine deaminase, ADA, it will be high. And actually, the criteria to diagnose that will be having lymphocytes like more than 70%, and adenosine deaminase like more than 40 or something. So there is like a criteria. I'm not going to ask you about them. It's like for level of resident or fellow. But once you think about TB and the patient have pleural fluid, just remember that you need to get that fluid out, send it for analysis as you do for any pleural fluid. And then if you're thinking about TB, you want the lymphocyte to be high, you will send for ADA, adenosine deaminase, and looking for a high number there. Not necessarily all of them will be positive, but again, it will if they are high, will support the diagnosis strongly. Also, you can have endobronchial TB. So that's the pulmonary. Then you have the extrapulmonary TB. The most common one will be lymphadenitis. It's the second most common after the lungs, usually due to reactivation. More common somehow in women, children, HIV patients. And involvement of the cervical lesion, that's what we call scrofola. It's a chronic, so the patient can chronic swelling, red, as you see in this picture, non-tender lymphadenopathy. Some of them, they might complain of fever. But again, once you see this, for sure, you'll think about biopsy, and TB will come in your mind. The other one will be CNS tuberculosis. They can present as meningitis, intracranial tuberculoma, spinal arconditis. The patient will present with malaise, headache, confusion, low-grade fever. They can progress quickly, and they become like to coma, seizure, paresis. Again, when you have other extrapulmonary TB, you try to get samples from there. If it's lymph node, I want the lymph node biopsy. If it's pleural fluid, I wanted the pleural fluid. If it's CNS, I wanted the CSF. The common finding or the typical finding will be low glucose, like bacterial infection, elevated protein, but then you will have lymphocytosis. Usually, if this left untreated, the prognosis is bad. People die or patients die within weeks. Also can affect the eyes, causing endophthalmitis, and can affect any part of the eye, but usually uveitis. It can cause granulomas, like choroidal granuloma. The bone and joint TB, the spine is the most common, but can affect any bone. The hip and knee are more common, but can affect any joint. So it can cause anywhere. The discitis and osteomyelitis, they call it the Post disease. It's most commonly affect the lower thoracic, upper lumbar. I just had a patient like 3 weeks or 4 weeks ago, which is weird story, but it started, he fell down from a horse, and he had like fracture, I forgot, T something, T1 or T2. I forgot exactly what's the level, but it was in the thoracic, upper thoracic. He was doing fine, but still having pain, and then the pain got worse. Came back, he found an abscess. They get biopsy, it was TB. I don't know. He had, I mean, I don't know how the pathogenesis in this patient was. Like, he was like maybe exposed and have some latent TB in his spine, and this fracture just reactivate this infection. I don't know, but yeah, you see it in mainly, like most common in the thoracic or upper lumbar. Also, they can have an abscess. Sometimes there is something called Ponset disease. It's a just rare, reactive, symmetrical, immune-mediated polyarthritis. It happens or occurs with the active TB. I think here with active TB, maybe it's primary TB. I have to double check. But anyway, it's just something for fun. It's just rare. You don't need to worry about it. GI TB, any part of the GI. Sometimes some patients can be like misdiagnosed or handled as inflammatory bowel disease, and it's just TB. Ileocecal disease is the most common. It can cause also TB pericarditis. It can cause to genitourinary and cause TB there. Patients present with the typical pictures of infection there, but then either they're not responding to the typical treatment, or the initial workup for most common causes are negative. If you have the correct epidemiological setting and clinical setting that you're worried about TB, then you need to think about it. This is ameliorate TB, which is a form of active TB. It's disseminated, usually seen in the first 6 months after exposure. It can be fulminant. Lung involvement is almost always present. And the most common finding when you do the chest X-ray is having these diffuse micronodules bilateral. Most commonly will affect the elderly or infants, and also can affect or happen in immunosuppressed patients. So when you suspect an active TB, the first thing you want to do, isolate the patient in negative pressure room with airborne precaution. You want to protect yourself, protect the patient, family, nurses, hospital. So once you think about the TB, you have to, it's okay. Maybe you are wrong after 2 days. That's fine. It's a different diagnosis, but it's better than being sorry later on. Oh, sorry, we have to test all these people who are exposed to this active patient because the one who saw the patient didn't think about TB. When you think about active TB, the diagnosis, I mean, we send the screening test, but they cannot support it. So, I mean, they can support, but they don't roll in or roll out. I mean, if you don't have anything positive and you still really kind of swear it's TB, and the IGRA or the skin test come positive, this can support you to go with TB. But again, if you think about TB and one of them is negative, I'm not saying this is not TB. So mainly we use them for screening, but we also send them during the active disease just to support. But again, they don't rule in, they don't rule out disease. You get the sample, and you can run one of these tests. So if it's pulmonary, I want sputum. Either in sputum, if he has productive cough, give me sputum. If he doesn't, induce sputum. If he can't, can we do bronchoscopy and get lavage, and then run one of these tests? I will do the FB smear. For sure, I will send for mycobacterial culture, but again, the culture will take long time. So the smear will help me. Usually when I isolate the patient, I need 3 samples to make sure he's not infectious for others. And we can send for the PCR or the NAT. Nowadays, they are faster compared to culture. They can give you, some of them, they give you also resistant profile. They can give you, it's not resistant or resistant to rifampin, so help you also when you want to treat the patients. Of course, the culture, as I said, it's the gold standard because it's the most sensitive. They have 2 media, it's solid and liquid broth, yeah, so 3 initial sputum culture should be obtained like within 1 hour, within first day. So usually you get in like 8 hours apart, 3 samples within the first day for culture and for AFP smear to see the infections. And here's the sensitivity. So the smear to be positive, you need 10,000 colony forming unit per ml. So you need really high burden of disease to give you the smear positive. But if, you can be sick with active TB, but you don't have this really high burden, a lot of mycobacteria in your sputum, so this smear will be negative. But if you do the PCR, you need only 100, okay? So it can be positive. But then for the culture, you only need 1 to 10. That's why the culture is the most sensitive and still the gold standard. Again, once you diagnose TB, you will send for basic lab, CBC, renal function, liver function. Again, this is for general status. And as always, I say, like when in the bedside teaching, you follow up the patient, you need these tests for side effect or for other things. Of course, you need the chest imaging. As I said yesterday, all patients with HIV screen them for TB. All patients with TB screen them for HIV. Why is that? As you saw in the figure, a lot of them, they progress rapidly to infection. They are more likely to get bad disease. Then you get in the dilemma of when to start HIV treatment, when to stop. I'm worried about iris or not. And then you go for organ specific. As I said, if you think about pleural, I want a pleural fluid. If it's pericardial, I want a pericardial fluid. If it's peritoneal, it's the same. If it's lymph node, I want to get lymph node biopsy. If it's CNS, I want the CSF and biopsy for any place that's infected. If, for example, some patient presented like with I think the group yesterday, I told them about this case. It's really weird patient with just fever and lymphadenopathy, mediastinal lymphadenopathy, cannot be reached by biopsy here in Breda. So, and also she had like pancytopenia. So one thing we did, let's get bone marrow biopsy. We need to check it for why she has pancytopenia, and also to test if this is an TB. So the treatment for active TB, usually the four called RIPE or rifampin, isoniazid, perzenamide, ethambutol. So RIPE. This is usually the first line if you don't have resistance. The duration, usually 6 months. You start with this consolidation or initial phase, all the four, and then you continue with 2 of them, the rifampin and isoniazid. The duration, if it's just pulmonary without cathetery and the patient become negative, the culture, like the sputum culture quickly become negative, then 6 months is enough. If it's cathetery lesion or the culture positive stay more like a month or 2, or if it's a bone and joint, usually you go longer, like 7 months. So the total will be 9 months. Here it's the same for bone joint. CNS, usually you go longer, from 9 to 12. And most of the time we go by clinical. I mean, we don't go less. So here we say 9 to 12. So usually I will treat them for 9 months or more. I'm not going less than 9 months, but then will depend on how the patient is doing clinically. For example, if he has like, let's say spinal TB, I will treat him for 9 months, and then I will check MRI, I will check inflammatory markers, make sure everything okay, patient clinically stable, then we'll decide when to stop it. So yeah, other things in treatment, vitamin B6 or pyridoxine to prevent the neurotoxicity for the INH. CNS tuberculosis, we use steroid for them. There is a protocol that you use them for dosing and tapering over 6 weeks. Before it was used for TB pericarditis, but now it's not routinely used. And of course, you need to pay attention for drug-drug interaction, and mainly we're talking about rifampin here. It has a lot of drug-drug interaction. Then you need to make sure, like if the patient in warfarin or patient in other medication, that will just be less effective or more effective. So in both sides. So either like when you start the rifampin, let's say I forget how it's affect. Let's say the warfarin. So when you start it, then let's say it will decrease the efficacy of warfarin, then you need to recheck the INR more frequent and adjust the dose of warfarin. When you're done with the course, you will do the same story again. You will check INR, go back to the dosing, lower the dose, and so on with other diseases, with other medications, sorry. The adverse effects, the most common we think about usually, and that's why we check the liver function test prior, and then a month later, or if the patient becomes symptomatic because of the hepatotoxicity. All these 4 can cause 3 can cause hepatotoxicity. The most notorious will be isoniazid, but then the others also can cause hepatotoxicity. Peripheral neuropathy, INH, optic neuritis, ethambutol. So usually we do the color vision test. The color vision is the first affected, and usually we do the test. I forget its name right now, but we test them in each visit while they are in ethambutol to make sure it's not affected. Perzenamide can cause arthralgia, And I think you know that the rifampin can lead to orange red discoloration of the body fluids. They can notice their urine become more orange or tears or something like that. So you follow up, you again, baseline LFT, CBC, creatinine. After 2 weeks of therapy, we need to obtain a weekly sputum smear to make sure it's smear negative. So once it's become negative, you get a sample on separate day to confirm non-infectiousness for culture. It's the same for culture here, monthly culture until 2 consecutive negative culture. And as I said, monthly clinic exam. Do the liver function test every visit, every monthly visit. Others will say if the patient complain of symptoms or sign of hepatitis C, then you check it. You do the color discrimination test, or Ishihara, I don't know how to say it, Ishihara color discrimination test, only while the patient in the So if it's treatment over active TB, that means you will do it twice while he's in active treatment, or 3 times max. So just again, recap what to do if you have active TB: isolate the patient, rule out infectiousness. How to do that? 3 sputum sample. You want them all negative. If it's positive, you treat, and then you repeat them until they're negative. Using the samples, if it's sputum, biopsy, or whatever, you want to do the AFB stain or microbacterial culture or PCR. You also want to check the histopathology if you are sending a biopsy or a tissue sample. This is if it's pulmonary. If it's extrapulmonary, then again you will send other tests, whatever it is needed, like pleural fluid, for the same things. I think I need to correct these 2 lines. It's kind of the same story. Then you treat for active infection once confirmed. As I said, these tests do not rule in or rule out active disease. You order them to help you diagnose, support you in the diagnosis, but they don't rule in or rule out. The reason I keep saying this, because I see it all the time. They will just test, and the patient is not really fitting with the TB, but they said, oh, it's interferon is positive, so are we worried about TB? Again, you don't screen it, it's support, but you have to do the other things too. There is something treatment failure. How do we define it? Positive culture after 4 months of therapy, or we call it relapse. That means after you complete the therapy and apparent cure, you have a recurrent. And this is a different story. I'm not going in details about them. One thing to know: there is a second line TB drugs. There are injectable. There are fluoroquinolone like levofloxacin, moxie. Injectable like strep2, amikacin, kanamycin. Others like linezolid. Then there's like new drugs like clofazimine or bedaquiline. A lot of studies about them right now. Imipenem. But again, I haven't used all of these, but because my practice was mainly in areas where I don't see drug resistant or multi-drug resistant TB. I remember, like, I saw a resident from Mecca. He was like, he was just mentioning all the second line. I was like, wow, you're really good in TB. But the reason they have a lot of patients from, forget Burma or Burma, I don't know where, something in Africa, where they have a lot of drug-resistant TB. So he was so familiar with first line and second line. For you guys, just remember there are second line when it's a drug-resistant TB or failure of treatment. There is the multi-drug resistant TB and extended or extensively drug-resistant TB. As I said when we talked about the epidemiology, there is an increase of drug-resistant TB, especially in India, China, Russia. They define multi-drug resistant as resistant to both isoniazid and rifampin. So the two major medication in the primary regimen they're resistant to. Then you have the extensively drug resistant, and they define it as MDR, these two, plus resistant to fluoroquinolone, any fluoroquinolone, and at least one of the three injectable agents. It's just definition, but just to keep it in mind. So TB in special population, I think I talked about it in HIV in detail. It's not in detail. Just to give you an idea, it's important to consider or think about TB when it comes to HIV. The other thing, like transplant, pregnancy, alpha inhibitors, again, because the risk to get TB, the risk will be high to have reactivation. So that's why for latent TB. And then when it comes to the pregnancy, it's a special population because you get in the dilemma of is it really infection or not? Do I have to treat it? What to treat with? Do I wait? Not after pregnancy. If it's latent TB, usually you wait. If it's active disease, of course you will treat. But then nothing without side effects. Most of the medication we use for TB kind of, a lot of studies that, okay, you can take them during pregnancy and you have a good outcome with your pregnancy, but it's different. You're not healthy. So it's kind of a special population when it comes to TB. Okay. So just, that's the summary. It's an important, latent versus active, primary versus reactivation. You have pulmonary versus extrapulmonary. The way to think about it, it's just appropriate clinical setting. Symptoms and sign that fits the TB, and then you have also the appropriate epidemiological setting, either the patient from endemic area or he has a recent exposure. And again, for latent TB, you must rule out active TB. Again, isolate the patient, and if a special population with TB, then you need to be pay more attention for those patients. And that's it. Any questions?
السلام عليكم دكتور. عندي سؤال أو سؤالين دكتور بهذه المحاضرة، وسؤال عن محاضرة HIV، بس إذا خلصنا يعني تماما نخلص الأسئلة ممكن. أولا دكتور, the screening test قلنا إذا positive you have to rule out active TB. أسوي لها rule out عن طريق culture ولا عن طريق acid fast dye ولا عن طريق chest X-ray؟
History, physical exam, chest X-ray.
قصدي صار عندي positive tuberculosis test, for example. How to rule out?
You do history, physical exam, full history, full physical exam, and chest X-ray. So for the history, you want to look for any sign or symptom that makes you worry about an active infection. And usually we focus on pulmonary symptoms. Then you do the physical exam again, just to listen and examine mainly the lung, but also other things, lymphadenopathy. If all negative, the patient is totally asymptomatic, the physical exam is fine, then the third step also, to complete the ruling out of active TB will be the chest X-ray. You don't want to see any kind of active infection going on. If all these unremarkable, then you treat them for latent. It's not active.
تمام. دكتور, من ناحية isolation of the patient with active TB, I should isolate them for 1 month or for 2 weeks and wait for the culture.
لا, هو الايسوليشن طبعا mainly البيشنت غالبا اللي بيجيك سك برايمري انفكشن بيكون بيجيك للاي ار. فاذا انت if you're going to admit the patient, you want to isolate him, put him in a negative pressure room, to isolate the patient from to expose other healthcare workers like the nurses, us, visitors, الناس اللي بيجيبوا لهم العشاء، الناس اللي بيدخلوا ينظفون الغرفة عندهم. That's why isolation. It doesn't mean the patient has to stay in the hospital in isolation. حتى بالمستشفى, if the patient is, let's say, I want to send him for CT or MRI or whatever it is that you want to send him, he just cover himself with the surgical mask, the regular surgical mask. Once you reach the diagnosis, you send him home and treat him. You like in the initial phase, like with the treatment, you can recommend like wearing surgical mask if you go outside or be with others until you get like the negative sputum sample. Clear or not? So هذه اللي هو يعني he doesn't have to stay for 2 weeks in the hospital. Let's say we diagnose him in TB, he's okay, he can take his medication and go home, he will go home. And as I said, you will just instruct him to wear the mask if he's with others. But then every week I will get the sputum smear to make sure his when this become like negative, that means he's not infectious. But again, once it's negative, I want to confirm that. I will repeat 2 additional samples to confirm that he's non-infectious anymore, and then he will be okay.
تمام دكتور. استخدم
طبعا
الفاست سمير.
طبعا دقيقه عبد الله، طبعا هذا عشان الانفكشسنس، يعني انا ابغى سمير نيجاتيف لانه الريسك to infect the others is high when the smear is positive. Okay, so here it's kind of maybe it's confusing for you guys. So I will treat him so I will send him with a treatment, or if he's in the hospital, after a week I will send the sputum for AFB smear. If it's positive, continue treatment, repeat it the next week until it's negative. Once it's negative, I want just 2 additional sample, like the same thing we said before. I need 3 samples to make sure he's not infectious to others. So once all of them negative, then he's not infectious, but doesn't mean he doesn't have TB. So sorry, doesn't mean he cleared that TB, because as I showed you before that you need 10,000 for the AFB to be positive, but you need only 1 to 10 for culture to be positive. So this is the smear for infectiousness. Okay, the culture for the cure. You want to make sure that the patient is really heading the right direction. So you repeat like monthly culture until like 2 of them negative, and then you stop sending culture. أيوة.
واضح دكتور. إذا ممكن دكتور أسأل عن اللي هي ال HIV إذا ما في شيء.
لا خلي إذا في أحد ثاني عنده التي بي ثم نرجع لك.
دكتور سؤال بالنسبة للإيج، ريسك فاكتور للرياكتيفيشن، طبعا هو متعلق بالاميون سبريشن اللي فيسيولوجيكال يعني اللي يتغير، لكن هل هي ميجر ريسك فاكتور لو اقدر اقول ايج يعني؟
It's a risk factor. انت وش قصدك؟ وين اللي انا قلتها هذه؟
اقصد بالليتنت او دورمنت يعني تي بي ريسك فور رياكتيفيشن، واحده من الريسك اللي هي اميون سبريسيف ستيت. طيب الايج older age risk factor.
هي غالبا لما تصير infection ولا نتكلم عن infection بالelderly we can explain because the immune status حقهم it's not as healthy 20 or 30 years old. بس ما تقدر تقول الايج it's an immunosuppressed case. لا
يعني مو major risk factor for reactivation يعني.
اذا انت قصدك عن معلش انا جالس ارجع الحين ما ادري انا. انت قصدك هنا مثلا هل نعتبرهم من الاميونوسبريست فلذلك اخليهم 5؟
لا قصدي مثلا لو كان واحد عنده latent تي بي وتقدم بالعمر، ففي يعني هاي ريسك للجروب هذا انه يكون له اكتيفيشن بروجريس يعني.
usually yes, general speaking yes، بس مو بانه معناته انك يعني هي بالاخير صح ما في yes or no. بالاخير انت الريسك for progression it happens yes it's increased with age او مثلا increased with the pregnancy or any other condition that affect your immune status, or it's not you're not in your 60s or 70 you're not as you when you are in 20s 30s. But again sometimes like some difficulty like I remember like patients for whatever reason somebody sent the quantiferon for him and he was I forgot like 85 or 90 years old. الآن إذا بتمشي على السؤال حقك تقدر تقول oh he's very old معناته الريسك حقته عالي انه تجي رياكتيفيشن. That's true. بس الستادي اللي تكلمت عنها تو او البرسنتج انه once you get exposure or infected you have a 5 to 10% in your lifetime to get reactivation. you can say it the other way انك تقول اذا هو جالس كل هالعمر ولا حصل له رياكتيفيشن ممكن اصلا eliminated. ما هو من ال 10% ولا البرسنتج اوف بيبل اللي بيحصل له رياكتيفيشن. تدخل بالديليما هذه هل اعالجه ولا ما اعالجه، هل بدخله بعطيه ميديكيشن ممكن تسبب له هيباتايتس ويموت من البروبلم اللي من الميديكيشن اللي انا معطيه. تو انسر يور كويستشن لا بير سي الايج لا لكنه اذا think if I want to think about infection usually with age you're more likely to get the infection. ما ادري وضحت علي ولا لا، اتمنى انه وضحت.
ايوه دكتور واضح
ممتاز.
دكتور بس سؤال اخير بالنسبه للتريتمنت، السكسس ريت بالنسبه للتريتمنت للتي بي ديزيز هل هو كبير؟ يعني
It's good. I think ان اللي حطيت لكم هذا الانيوال ريبورت من السعوديه كاتبين الكيور ريت او سكسس كيور ريت كان above 86%. فايتس جود. طبعا نتكلم السعوديه again it's their first صح في big hospitals وفي follow up احيانا you have really يعني again I'm not expert بالتريتمنت والفيلد لكن اقصد ما عالجت ناس كثير بالتي بي هنا عشان اشوف لا لكن اللي يتوقعه انه الادهيرنس بيكون عند بعض الناس. again تتكلم انت عن عماله، تتكلم عن البوبوليشن اللي غالبا بمجتمعنا يسمعون من المجالس. يعني عادي مثلا تلقاه يتعالج ويقول لك لا تكمل 6 شهور ترى لا هم يطولون خلوا شهرين ونص ممتاز طيب ويوقف. فالان يعني تحتاج ستادي اذا قلنا 86% الكيور ريت ال14 هذه ليش صار لهم فيلير. يعني اذا ما عندنا ريزيستنت وما عندنا فيلير، اذا كان مثلا الادهيرنس معناته الكيور ريت قليل هذه ما هو 100% لانه مو لانه الميديكيشن سيء او لانه الديزيز صعب، لا simply لان البيشنت are not good taking their medication. But still 86% is good. And you can look it up for بالتقرير هذا الريبورت السعوديه. just اكتب التي بي in Saudi Arabia ويطلع لك على طول.
جزيلا دكتور.
seems to be usually primary or reactivation. غالبا you're thinking about reactivation. It can happen as a primary but you think about reactivation. وين اللي كنت حاطه؟ You see here disseminated. It can happen as a primary. It can happen as a meningitis or miliary TB. But again, in general, not only the CNS TB, all of the TB, most of it is like will be activation. 90% will be latent, and then a huge percentage will be reactivated. Any other question about TB قبل ما نروح لعبد الله عن HIV؟
صدق دكتور نسيت سؤالي، انا احاول اتذكر عجزت.
جود. انا حسبتك طلعت عشان زعلت ما جاوبتك، قلت كويس انه رجع.
طيب. لا الانترنت سيء عندي اعتذر.
الله يعين. طيب في اي سؤال يمكنك تتذكره خلال الدقيقه؟ اذا في اي سؤال بليز شوت، otherwise feel free to go. ان شاء الله ان كلكم حاضرين 51 يعني نفس امس 3 ان شاء الله يعذرونا ترضون عليهم انهم موجودين ما تزعلون. اوكي يعطيكم العافيه. If you have a question عبد الله ما تذكرت الحين تذكرته عقب ما تفطر send me an email. I'm happy to if you have any other question just email me.